أو غير عربي يشارك ويستمع إلى هذه المحاضرة الأولى، وهي أول فاعلية للمركز الوطني لتقييم الكفاءات الطبية. المركز الوطني لتقييم الكفاءات الطبية الذي يرأسه الأستاذ الدكتور صبيح المشهداني، ويضم نخبة من الأطباء وعلماء الطب والأساتذة من مختلف الدول العربية، من العراق، من الأردن، من تونس، من مصر، من السودان، وهو مفتوح بالكامل لكل الدول العربية. الهدف الأساسي للمركز الوطني لتقييم الكفاءات الطبية هو تنمية البشرية في المجال العلمي وفي المجال الطبي. والتنمية البشرية هي أعظم وأغلى وأقيم أنواع التنمية. مش هاخد وقت طويل لأن احنا اليوم مع محاضر هو أستاذ الدكتور عمرو هاشم الصفار. هو عامر هشام الصفار هو fellow of the Royal College of Physicians in London. He is a lecturer in medicine, Cardiff University Medical School. He is also consult. أنا رجاء اللي فاتح الميكروفون يقفله. وهو أيضا consultant physician in NH Wales. He is also professor of medicine in Basra University. دكتور عامر اليوم سيكلمنا عن موضوع في منتهى الأهمية، عن Mastering Clinical Communication Essential Skills for Doctors. Please دكتور عامر.
شكرا. Thank you very much. شكرا أخي دكتور أحمد، وشكرا للأخ الدكتور صبيح على هذه الدعوة، وشكرا للمركز الوطني لتقييم الكفاءات الطبية. Our subject today, if I can share a few slides with you, and I hope you can see all the slides now. And this is the first slide, is about the title of this presentation. It's about clinical communication skills. And it is really very important to have these skills and to master the skills in communication. If we can do it, by all means, we need to do that. I have no interest to declare, so no conflict of interest for me here. And as you know, there are few books and many research papers in medical education journals about clinical communication skills. And this book, for example, Medical Analogies for Clinician-Patient Communication. The editors, Muhammad Azan Khan, with Hamza Ashraf and Qasim Ashraf. And this is, as the book is saying, simplifies conditions, for example, by comparing them to relatable concept before discussing potential treatment options. So this is innovative strategies for improving the clinical encounter, and based on the clinical or clinician-patient relationship. This is really very good book, and it's a new book, relatively, published in 2022. There are other references, of course, and as you can see here is effective medical communication and patient-centered communication. And the book, actually, I got a copy of that book, Patient-Centered Communication. And it is really very good book, sharing stories from different medical specialties, and focusing on the patient and the service which is focused or centered on the patient as well. And the medical journals, every week I read the BMJ, I read New England Journal of Medicine, and I read the Lancet and Lancet Neurology. I am geriatrician and a stroke physician as well, so we do sessions, working at least 2 to 3 sessions a week, depends on the pressure of work in stroke and TIA management. So if we go through examples, for example, today, if we go through examples of communication, it will be based on my practice in stroke medicine and TIA clinics. But why I put this slide is just to alert you. the fact that we have in different medical journals, we have subjects related to clinical communication and the need to partner with patients. So this is, for example, patient partnership, time for patients to have a seat at every table, which is really very important now in Britain. Even in the Royal Colleges, we have stakeholders and we have the patient's representative, because without them, the idea of caring for the patients themselves is not going to be comprehensive. So if we can find an objectives, and all of us are very concerned about the quality of the health service that we provide and the quality of the doctors that we are graduating from different medical schools from our countries and even in the developed countries as well. So the enhancing the communication abilities of the healthcare professionals, I would say, equal how crucial and how effective is the patient care. So it is crucial for effective patient care is the enhanced this communication abilities or communication skill. So the aim is how to improve patient-centered communication. And I should say that this is based on understanding by the doctors to patient needs and the skills to actively listen to the patients and understand patients' concerns, preferences, and expectations. Of course, we all work in very pressured circumstances. We are under pressure. Time-wise, we are under pressure. NHS in UK, and as you know, in United Kingdom, we have Wales, we have England, and we have Scotland and Northern Ireland. And the NHS is for the whole country service. And the main thing now is this enhancement of the medical education based on a new and innovative programs in medical education to produce good quality doctors with good quality outcome of their work of the medical service and good quality NHS service. Because NHS is a free service at the point of delivery. So you need really very good quality of care and of patients. And there are parameters to measure the quality of the service and the quality of medical education. Part of it is obviously medical education. And then it is based on this building rapport between the doctor and the patients. So it's all based on our teaching techniques for establishing a trust and rapport with patients to improve the therapeutic relationship. And that's really very important for doctors. And part of it, obviously, is the focus on the patient themselves. And the doctor should give full attention. That's part of the communication skill. Of course, we do these courses of communication skills in our NHS. We do it in sort of role model, for example, and actively engage with the medical student or with the trainee doctors in a hospital setup. As I'm working in hospital, and we send newly qualified doctors to the family doctors' clinics as well. So they see patients at the primary health centers rather than the secondary health center, which are the hospitals. But the principle is the same. The focus is on the patient. So we give attention. If you ask me about the time limit for any consultation in Britain, for example, the GP or the general practitioner family doctor has only 8 minutes maximum for each patient for the whole consultation. So in these 8 minutes, you should listen to the patient, take full history, examine the patient, think about the diagnosis and differential diagnosis, and make management plan in these 8 minutes. How they can do that. Okay, and don't forget, we have in Britain, for example, here in this country and in developed countries, electronic health record. So the health record of the individual patient is available to the GP and to the hospital doctor at the time of seeing the patient. And maybe before seeing the patient, they went through the medical record of the patient to make the consultation time shorter and easier and more focused. But the principle remains the same. I should give full attention to the patient and avoiding interruptions and distractions. Because the patient, if you are distracted, if you don't pay attention to the patient, if you interrupt the patient and don't listen carefully to what they are saying as part of the story for at least 2-3 minutes, then you are not going to achieve this rapport that I was talking about, this relationship, this kindness in dealing with the patient. And that will reflect obviously on your health, on the productivity or on the quality of the healthcare. And then reflecting and clarifying, so you should summarize what the patient says and ask clarifying questions to ensure understanding. And non-verbal cues is really important as well. Maintaining eye contact, leaning slightly forward. So your sitting position, listening to the patient. Patients are clever human beings, and they are suffering. They are under pressure because of the disease, whatever this disease is, and they want real attention by the doctor who is going to look after them. So encourage dialogue, obviously, and use open-ended questions that allow patients to express their thoughts and concern in their own words, rather than simply answering yes or no. It's an open-ended question. And exploring concerns, ask questions that help explore patients' feelings and patient symptoms and expectations, as obviously this is a routine, but you need a skill. And the skill comes with experience, with the training. And I will say that, and there are papers. This is a new paper published in the British Medical Journal, the BMJ, listening to patients at all levels of healthcare. So our medical education, we are always in like a challenging atmosphere, because of the complexity of the product of the medical education and the doctors, and the complexity of the work of doctors and their relation with patients, and then the quality of the health service. So always we discuss how much you listen to the patient, how you listen to the patient, or how long you listen to the patients, and what is the art of listening to the patients. So all this, we write about it sometimes, and we share thoughts, and we publish sometimes as well about this. So effective communication skills may be written communication, non-verbal communication can be presentation skills, patient education, you educate patient when you explain about the disease. It's compassion, you are compassionate doctor. Cultural awareness, should be aware of the background of the patient, especially in our community. For example, in Britain, it's multiculturalism, and many people from different countries living here, and they are resident, and they are naturalized, and we should look after them. Personal connections, trust, effective communication skills, build the trust as well between the doctor and the patient, and obviously verbal communication and active listening, as I said. So the importance of communication skills in medicine is patient-centered care, is effective communication is fundamental to patient-centered care. It involves not only conveying information clearly, but also listening attentively to patients. It's two-way communication, and foster trust and helps tailor treatments to individual needs. And the benefits, good communicator, good doctor, good communicator. The benefits of that for doctors is reducing stress and burnout for doctors. I might ask one of my colleagues to close the microphones for there is an interruption. Okay. So it's reducing the stress and burnout. There was a study about this subject, actually, why good communication reduces the burnout and stress on doctors. It's 1,133 UK hospital consultants. 27% of them showed evidence of mental health issues, the doctors themselves. And there was a study concluding that good communication with patients reduce the stress and burnout for doctors because it is related to reducing the complaints and litigation. Because patients have good relation. Patients have been informed in a kind way, compassionate way about what's going on. And for patients, obviously, give them satisfaction. If the patient is satisfied, whatever is the outcome of the disease, then the litigation is less, and the stress on new doctors is going to be less. And obviously, all this will improve the health outcome, which is the aim for all of us. And this is another paper from King's College London, published in 2015, about enriching clinical communication teaching, a qualitative study of a curriculum field in UK medical schools. So that's a qualitative study based on conversation and dialogue and interviews with doctors, and it is really very good. So there are many studies. The subject of clinical communication skill is in itself is a subject for study and research, which is really important for us as educators. We are not only doctors, we are medical educators as well, and this is part of our interest, is the clinical communication. Right, so this is self-explanatory about the skills and the knowledge and learning. All goes to this from the skill. So you are skillful in your knowledge, in your ability, in your training, in your competence. So that's part of the good doctoring or good clinical service. Empathy and compassion is important, needless to say that. Expressing understanding, verbally acknowledge the patient's feelings and sympathize with the patient. Supportive presence as well, so you maintain a compassionate tone and demeanor, reassuring the patient that their concerns are being taken seriously. And that's really very important in all specialties of medicine. Clear and concise information delivery, without using medical jargons, complicated ones, simplify them as much as possible, and structured information as well, present information in a logical sequence, and that is really important. Non-verbal communication, I mentioned that earlier. Engage in small talk or show interest in patient's life. That's how to build rapport, needless to say. Of course, that's part of the common sense, especially for GPs, because they are family doctors and they have been looking after certain patients, not as patients, but as individuals as well. So they know the patient, they know the family, they know their social circumstances, their education, their career, and they have very good rapport with the patient because they've been looking after them for many years as a primary care doctor. So that's really very important. For hospital doctor, again, that's important, although the time, you don't have time, so it's shorter time for the GP, but the GP might feed back to you. So that's the benefit of this system, that we have communication between doctors. Primary care doctors feed back to the secondary care doctor. So the hospital medical staff, they have always feedback from the primary care doctor and the GP. So I cannot see a patient in my clinic without a letter from the GP. Obviously, that's in addition to what I'm going to get from the patient by taking the history quickly and listening to the patient. So that's a trust building. Be honest, transparent, respectful in all communications to establish and maintain trust with the patient. Patient education and instruction is important. I explained, the surgeon should explain the procedure very clearly to the patient. When I thrombolyze the patient, obviously, I take consent from the patient, stroke patient we are talking about. If the stroke patient is unable to give me consent because he might be confused, might be unable to speak, then I go collateral and I go to the parallel history, like the relatives, wife, daughter, sons, whoever is present with him, neighbors, even the paramedics, the ambulance driver and the paramedics, the nurses, whoever knows anything about that patient. So I need the history. And I explain, if the patient is aware of what's going on, I explain the procedure of thrombolizing the patient and the complications following that. So always this build on the communication is very important. So clearly explain procedures, treatments, reasoning behind them, and allow patient to feel informed. That's really important. Assessing understanding, ask the patient to repeat instructions or information to confirm their understanding, just if you have time to do that. And summarization closure, key points. At the end of the conversation, we summarize the main points discussed to ensure mutual understanding, and clearly outline the next steps, including any follow-up action. That's very, very important. For example, when we have TIA patients and that TIA patients needs further investigations, for example, full blood count, blood tests, and lipid profile and glucose level, and I might do a carotid duplex, for example. Blood test can come within 48 hours. Carotid duplex, the result will come within 1 week, for example. So all this, I'll keep the patient informed, and I will let the GP knows as well. So it's not only you communicate with the patient, but you communicate with the primary care doctor who is in Britain. And that's the benefit of your center as well, and the global network for the center of Kifayat al-Tibbiyya is to have different input from different health systems all over the world. And that's really very important as interaction and learn from each other and build up on our level of learning and the outcome of this and the level of health, quality of health that we provide to our patients. Professionalism and respect is really important. Part of it is cultural sensitivity. So we show respect for patients' cultural, religious, and personal beliefs, and adapting communication as needed to accommodate these beliefs and to accommodate the feeling of the patient and the beliefs of the patients. Confidentiality as well is really important. Ensure that all communications maintain patient confidentiality. And that's part of the professionalism. Speaking privately when discussing sensitive information. Needless to say, that's what we need to do, and that's what we are doing. How much information I give to the wife, the patient, without his consent? Well, it depends on this chemistry between me and the patient and the wife, for example, and the family. If I feel that the patient, if he is verbally unable to speak, because I have difficulties here, and there is a skill in how to communicate with disabled people as well, is maybe people with learning disabilities, how you communicate with them. It's all part of your journalism and part of contract for the service. Close the microphone, please. Close the microphone. Yeah? Okay. Structured communication techniques, SBAR and ICE, these are, well, we might do it without knowing that it is part of SBAR, but we do it as part of our common sense. Sorry, if you close the microphone. Ustad Jawad Fadel. Close the microphone, please. Thank you. Yeah. SBAR and ICE, essential tools as structured communication technique. SBAR, situation, S for situation, and B for background, A for assessment, R for recommendation. And the standardized communication method primarily used for conveying critical information in a clear, concise manner. For example, patient had a cancer diagnosis. I need to explain this to the patient. So the situation, it's important part of the communication skill. It helps structure conversations to ensure that all relevant details are communicated effectively. So the SFAR assessment, what do you think the problem is? I am, as a doctor, asking the patient. And the healthcare provider, in this case, in part of the assessment, shares their clinical assessment or interpretation of the situation with the patient. So, for example, I believe that chest pain may be related to cardiac ischemia or cardiac injury or reduction of the blood flow to the heart muscle. If I explain this to the patient, given the patient's history and current symptoms, so I share my belief, my diagnosis, my initial diagnosis, provisional diagnosis. R for recommendation. What do you recommend? And this is where the provider suggests a course of action or ask for specific intervention. Example, I recommend ECG, for example, possible administration of GTN. Can you also notify cardiologist on call? So maybe I need to explain this to the patient, and that is the case of chest pain, for example. The other thing, the ICE, the ideas, concerns, and expectations, is a communication technique used during patient consultations to explore patient's perspective on their condition, and patient's views, the worries, and expectations are understood and addressed. So we need to pay attention to that part. For example, I for ideas, what are the patient's ideas about their condition? They should have an idea. It will be nice from the doctor to ask the patient. This involves asking the patient what they believe is causing their symptoms or condition. What do you think might be causing your headache, for example? So I need to find out the patient's or her interpretation of the symptoms, and there might be clue to the diagnosis there. C for concerns. What are the patient's concerns? And this explores any fears or worries the patient has about their symptoms. Is there anything in particular that you are worried about? That's my question to the patient. Expectations. What are the patient's expectations from the treatment, from my consultation? I should know that. And what were you hoping we could do for you today? And that's really very, very useful to know the expectation of the patient. Shall I meet this expectation? Am I going to meet the expectation of the patient in my management plan? Is it sensible expectation? Acceptable in view of my provisional diagnosis? And all these issues. It's good communication in this way, because then I will be walking on the safe side of my practice, because I explained everything, and I told the patient my management plan, and I even discussed his ideas and his concern and his expectations, which is really great if we have time. But sometimes you need to integrate both the SBAR and the ICE in clinical practice, and that can improve the quality of communication, leading to better patient care. And this is, for example, when a nurse updates a physician about a patient's condition, SBAR can be used. ICE is used during patient consultation, ensure that healthcare provider fully understand the patient's perspective. It's all about the patients and ideas and expectations. There is another protocol called the SPIKES protocol, and that is structured approach used by healthcare professionals to deliver bad news, how to break bad news to the patients, their families. And as for setting up the interview, prepare the environment, choose a private environment, private place. We do have in every ward in the hospital that I'm working in a private room, and these are visitors. We call it visitors room, private room, where the visitors can have a cup of tea, for example. Not all visitors, visitors, or patients who is terminally ill, for example, or patients with complications because of certain procedure. And we need to discuss, we need to explain to them, so we take them to that room. It's a setup. And involve key people. And that is, if appropriate, obviously invite family members. Mentally prepared, gather all necessary information and mentally prepare yourself as a doctor for the conversation, because it might be difficult conversation. And P for perception, assess the patient's understanding before delivering the news. You need time, you need to relax about the atmosphere of this, or the environment of this meeting, and gauge the patient's current understanding of the situation. For example, what do you understand about your medical situation so far, or the medical situation of your relative so far? Have you had any concerns about your recent tests, for example? If you are meeting a patient following a biomarker for cancer, for example, PSA, for example, for prostate, and you need to explain, and especially the patient is educated, went through few reports over the internet, and he done his own research and find out the number for PSA, asking you about his number, and asking you about the possibility of this is maybe fault from the lab, or maybe there are other reasons which cause high PSA. So all these details and communication, your communication skill, you prepare yourself very well for different types of patients, and you explain in a way sympathetic, obviously, to the patient, and in a way that can reflect on your quality of service. I, for invitation, ask how much detail the patient wants. I from my own experience, I have about 10 to 20% of patients, they don't want information about the blood results or about the histology results, because they expected the worst. And you are not under any obligation to explain everything to the patient. The patient does not want that. Maybe the next of kin would like to know everything about the patients, but then you need to take the consent of the patient before you explain everything to the next of kin. So it's a bit complicated as well. So would you like me to explain the results of your test in detail? How much do you want to know about what we have found? All this are really very important information. K for knowledge. Deliver the news clearly and provide info in a straightforward yet compassionate way. Exactly. For example, I'm afraid I have some difficult news to share with you, and the test results show that the cancer has returned. Unfortunately, the results aren't what we were hoping for. That's the way just to start the conversation with the patient, and then obviously you put the results in front of the patient. Sometimes I use photos, I use pictures, I use diagrams, I use figures. Why not? If the patient would like further information. And obviously I'll tell the patients about my team as well, and about the team which they might look after him in the near future because of the complications. So I'm a physician, I might need to refer the patient to the surgeon, oncologist, or the oncosurgeons. I need to explain to them that they are very good surgeons and they are very good oncologists, and why. So these are all to make this information in front of the patient is really very important for building up the trust between you as a doctor and the patient. E for emotions with empathy, and I mentioned that earlier. So, for example, I can see this is very upsetting for you, and that's completely understandable. Or I am here for you, and we will get through this together. That's good approach. S for strategy and summary. And discuss the next step, as I said, and summarizing and confirm understanding. From here, we have a few options that we can discuss. I want to work with you to decide the best course of action. And let's go over what we talked about to make sure everything is clear. And these sort of things, very important, very useful to the patient. So pace the conversation, allow the patient time to observe the information, and be prepared to repeat or clarify points as needed. Time is really crucial, very important in modern medicine. Time for consultation between patients and doctors. And there is, of course, there is always limit, but what is the best time for different consultations in different medical specialties? I can see from my practice, and I work with palliative care physicians, and palliative care is a specialty on itself, on its own. I can see them; they are spending much more time than me in their consultation with the patients because of the complexity of the care of the patients in their final days or final weeks of life. So that's, again, we need to study about that, actually. We need to study. I haven't seen any study about the time for consultation in different specialties in medicine. Are physicians spending more time with their patients than surgeons? Quite possible. Quite possible. Because surgeons are always in a hurry, and they have maybe shorter time for talking and more time for working and acting and doing the operation itself, different from us. So that's, again, what's the implication of the duration of the consultation on the outcome of the medical care? Shorter consultation may be wrong diagnosis. How accurate is the diagnosis? For example, is the accuracy of the diagnosis is correlated with the time of consultation? And that's really very important as well. So we need this type of research. We don't have this research. We don't have these papers. And I'm working with a few colleagues about these issues in our communication skill lab. We have a lab on that. Follow-up support after the conversation, ensure that the patient has access to additional support. Counseling, for example. So the SPIKES protocol is designed to make difficult task of breaking bad news more manageable and humane, and ensuring that patient feels supported and respected throughout this difficult process. The other issue that I put as part of this lecture is the informed consent and shared decision-making. And there are two key principles in modern healthcare that prioritize patient autonomy, engagement, and collaborative in the treatment process. So informed consent is a legal and ethical process by which patient voluntarily agrees to propose medical treatment. We had a problem a few years ago when we have a newly graduated doctor. She was part of her training to be part of the stroke team, and we were busy, so she was consenting a patient for NG tube, nasogastric tube insertion, because the patient had dysphagia, difficulties in swallowing following the stroke. And the patient was unable to speak. But that doctor, maybe she noticed that the patient was nodding. She thought that the patient has been informed about the NG tube benefits and complications. So she ticked the box that she consented the patient, and the patient gave her consent for the procedure. Which procedure? NG tube. Following the procedure, complications happened, unfortunately, and the son objected. He said, my mother was unable to give consent. So why you did the procedure for my mother without her consent? And I am, as a son, having the power of attorney on my mother. And the power of attorney in Britain, for example, is like something a patient declared legally that one of their relatives or friends is the representative in case of debilitating disease. So he said, I am the next of kin, I should be informed and I should be consulted, and the consent should be coming from me, not from my mother, who was unable, the patient, because she was unable to give consent. So this sort of legal issues, it's always informed consent is important for the patient, important for the doctor and the outcome of the medical care. So disclosure of information, the healthcare provider must give the patient comprehensive information about the nature of the proposed treatment or procedure, expected benefits and potential risks or complications, any reasonable alternatives, including the option to refuse treatment. The patient might refuse treatment. You cannot force a patient on the line of management that you are designing or you are putting in front of the patient. The potential outcomes, you should explain as well and disclose the information, the potential outcomes of not receiving this treatment that you are planning to give to the patient. And the patient must demonstrate an understanding of the information provided. And that's really important. As part of your communication skill, you will know whether the patient has understood you or not. Voluntariness and the patient decision must be made freely without any undue influence by anybody. And the capacity, as I mentioned, mental capacity. Patients should have mental capacity to make decision and consent. Once fully informed, the patient must give explicit consent, either verbally or in writing. And we have in Britain, in our hospitals, in the NHS, we have special forms for consent forms. Shared decision-making is a collaborative process. And that's, again, your communication skill, because you made a decision, but you need to share it with the patient or their relatives. So in which healthcare providers and patients work together to make healthcare decisions. So you have a decision in your mind, you made your mind about your line of management to certain condition of the patient, but you need to share it to see what the patient think about it. So exploring options. Healthcare provider presents all relevant treatment options and you share it with patients and then choose the one that is nearer to the heart of the patients, and in your scientific approach to all this, medical approach, ethical approach, you think this is the best way. So you should convince the patient on the ideal line of management. Understanding patient preferences as well. The patient's values, lifestyle, preferences are central to the decision-making process. Yeah, so the relationship between informed consent and shared decision-making, obviously informed consent is foundational part of shared decision-making, because if I'm sharing the decision, I am assuming that the patient is having mental capacity and is able to give me consent and consented to that decision. So the patient must be fully informed, obviously, before shared decision can be made. Right. And this is part of the forms that we have. And we give them leaflets as well about the procedure for which I'm asking for consent to do that procedure. So engaging patients in shared decision-making fosters a trusting relationship between the patient and the healthcare provider, which is crucial for effective care. Informed consent and shared decision-making are essential practices that ensure patients are active, informed participants in their healthcare. And that's really the idea behind it. Another example of the communication skill, clinical communication skill, is our own communication within the healthcare team, the interdisciplinary and the multidisciplinary. And that's really very important, because you don't only communicate with patients, you communicate with your colleagues as well. So clear and open communication, sharing patients' information, test results, management plan, and you see if there is any concerns from other colleagues, observations related to patient care. And that's actually even part of the ward round in medicine. You do the ward round with another trainee doctor, for example, might be another consultant, depends on the needs of the ward round, and definitely a staff nurse and trainee doctor, as I said, and maybe in my setup as a stroke ward, we do rehabilitation ward round, and that is when the physiotherapist is with me and the occupational therapist and the speech and language therapist, in addition to the nurses. And that is, in effect, is like a multidisciplinary approach. And in effect, we are communicating with each other. We are sharing the information with each other. And in effect, I might close the door of the ward and ask kindly the relatives if they are there. Obviously, I should avoid the visiting time when I do the ward round, so there are no visitors, and I keep the confidentiality of information between us only, the interdisciplinary, the team only. And this will obviously part of the team collaboration, multidisciplinary and interdisciplinary, respectful communication. We value each other's contribution. We very much value the physiotherapist and the occupational therapist in my specialty. Use technology. Electronic health record is part of routine practice in the NHS in Britain. Clear documentation, accurate and timely documentation. It's not late documentation. If a patient is unwell, I need to update the blood results, part of the medical record of the patient, because this is a legal document, medical record. عشان نقول بالعراقي قبلة المريض مهمة جدا, part of the legal documentation, and you are going to be asked about it in case of any problems. So you update it. You update. I done the ward round. I discussed this and that. The blood result is this and this, and it's part of the continuing education as well to our trainee doctors. Dealing with difficult conversations, as I said before, it's empathy and respect and active listening and stay calm and professional. There is conflict resolution skill, negotiate and compromise and all these issues. And there are difficulties sometimes in conversations with the relatives of the patients because of what happened to the relative, the patient. For example, complications which might lead to death of that patient, and the relatives are asking what happened exactly, because they haven't been informed that their patient is so ill to the degree that after a few days he passed away. You see, so that's part again of the communication. And that's what I said about documentation and digital communication. And nowadays all are electronic EHR, electronic health records, which I say transform the traditional paper-based records into digital format. And it's all very, very useful and very important. So we have the part of the ward, we have paper-based record, but the blood results, the radiology results, the lab histology results, they're all electronically based and digital format, and which is really very useful, very important. And I dictate the letters. So the letters we dictate, it goes immediately to the GP, and the GP can see the letter. And if I decide to send this letter to the patient for information, then I might edit the letter, because this is going to the patient. So I do two letters, one to the GP as my medically qualified colleague and understand medical jargons in my medical management plan, and one to go to the patient. which is edited. And that's important as well. If I decide to send a letter, not every patient I send them letters about their condition. And we can discuss this subject maybe in the future, the digital communication in healthcare, and what we can do about it. So that's what I have actually at the moment. I can show you more information about this subject. It's very close to my heart. I can talk about it for a long time, but I think I'll stop here. And obviously you can discuss and you can ask me questions, you can add information from your own experience. I'm quite happy to listen to you today. Thank you very much. Thanks a lot.